Thank you very much, dear chairs. Thank you for the organizers for the opportunity to talk about gender differences in GI cancer. And as you all heard just what the difference is between sex and gender, you don't mind if I continue to talk about sex difference, because I think at the current point in oncology, sex differences are more important. So, as an introduction in the topic, I would like to use a quote from Goethe: one only sees what one looks for, and one only looks for what one knows. And I would like to draw your attention to the fact that with this approach, we ignore what we don't know and what we don't look for. And I think this is what happened with the sex differences in oncology in the last decades. My talk will be structured as follows. Well, after a short introduction, I will talk about the sex differences in cancer biology, the sexual dimorphism in cancer, about gastric and gastroesophageal cancer, about colorectal cancer, then discuss sex differences in treatment effects of GI cancer, and a summary and conclusions. So why did I came to study this topic? This was really inspired by my patients, and one of these patients which inspired me to think about this topic was this lady, Mrs. C, 44 years old, with a gastric carcinoma, a signet cell cancer, treated with total gastrectomy, and it was finally a stage 4 disease. We found after surgery she got capox after surgery, and the tolerance was really very poor. She developed a meningeal carcinomatosis 6 months later and died 6 months after the diagnosis. And for me, I mean, being an empathic oncologist, this case really desesperated me. And I was desesperated for 2 reasons. First of all, I had the impression that the biology of this disease is different, and is different than everything I had seen before. That was one thing. I had never seen such an aggressive gastric cancer. And the tolerance of the treatment was really poor. I mean, I found this, she had nausea and vomiting and hematological toxicities, and it was just painful. And I had the impression that treatment had no effect at all on the disease. So I worked on this topic and did some research in the literature, even a systematic analysis, research for sex differences in chemotherapy toxicity, and we found about 40 articles reporting, analyzing systematically sex differences in cancer treatment, which is in populations of greater than 100 patients, a very, very small number. So, and some of these reports clearly showed significant differences. So this I identified as an area where much more work is to do. Furthermore, in addition to the differences in toxicity, there is something called a sexual dimorphism in cancer, and there are several arguments for this. One of them are sex differences in epidemiology, which have been observed by epidemiologists since decades. And what is interesting is that these sex differences persist as well. They are observed as well in children and in all races, and they cannot be explained by differences in risk factors. Furthermore, you already heard that that the hormones have multiple effects on extragonadal tissue. Probably there are differences in response to oxidative stress, and there are sex-biased gene expression signatures and actionable genes in multiple types of cancers, which I find really an exciting discovery. So, because we like to talk about gastric cancer in this session, you all know the molecular subtypes. If you look at the distribution of these subtypes among men and women, you find that they are not equally distributed between men and women. For example, microsatellite unstable cancers are more frequently observed in women. This is the data from the TCGA, and EBV-associated cancers are more frequently observed in men. Furthermore, you know that the chromosomal unstable subtype is in the stomach is the same disease, more or less, than for the systemic treatment, than the esophageal adenocarcinoma. And esophageal adenocarcinoma has a very steeply increasing incidence, and especially in men. The risk factors have been discussed, and multiple studies have investigated individual risk factors. But adiposity has been discussed, but male predominance of the incidence persists even in lean individuals. So this is really not enough. Individual risk factors are not enough to explain this difference in incidence. I think we need to look at the host as a whole, as Fatima just said. In my view, we have to acknowledge that the man's distinct genetic, hormonal, anatomic, and whatever aspects of the constitution play a role in combination with adiposity predisposed to the development of esophageal or gastroesophageal adenocarcinoma. The next topic is the genomically stable subtype. You know that many of these gastric cancers with genomically stable subtypes are of the poorly cohesive subtypes, and this was the case of my patient, which I presented in the introduction. This is a retrospective analysis of nearly 5,000 patients treated in a series of Korea, where they looked at clinical pathological characteristics according to sex. TNM stage and type of surgery were well balanced, but poorly differentiated and signet cell ring carcinoma was more frequent in women, and it was especially more frequent in younger women. And if you look at the prognosis of the younger women, they have a particular dismal prognosis as compared to in the age of under 45 as compared to over 45. Furthermore, the prognostic impact of poor differentiation and signet cell histology is more important in women than in men. For reasons for reasons we will discuss on the next slide. This very nice paper from Adam Bass' group has tried to better understand the molecular basis of early onset gastric cancer, and they did especially look at the subgroup of patients with early and onset diffuse gastric cancer. And what they found is that the predominance of diffuse histology and female sex in early onset gastric cancer may be related to frequent somatic mutations in Caterin and TGF-beta receptor. So there seems to be a biological basis for this really dismal prognosis in this patient, which we seem to find biological explanation for this disease, which really is not randomly distributed in men and in women. So in conclusion, talking about gastric cancers, differences in gastroesophageal cancers arising in men and in women include the distribution of the TCGA molecular subgroups, but as well within these different subgroups, the epidemiology and prognosis of a given tumor may be different. So in colorectal cancer, I have to be shorter. As well, the consensus molecular subtypes are not equally distributed among men and women. The CMS1 subtype is more frequent in women, and there's unfortunately very little data overall about the differences in the molecular biology between men and women with colorectal cancer. But in this series of over 1,000 patients, women had more often a younger age, peritoneal metastasis, BRAF mutant tumor, local regional lymph node involvement, and among all RAS wild-type patients, women had a worse overall survival. So next big topic are the treatment effects. Sabine told us already that in multiple disciplines of medicine there are significant sex differences which are well known, more or less well known, and in oncology we just have not investigated them. So 5-FU is one of our most favored drugs for the GI oncologists, and the pharmacokinetic studies of 5-FU, and there are several which have been done and clearly demonstrated that men have about 26% higher elimination of 5-FU, with the result that the plasma level in the women are higher. And the dosing according to BSA results in a majority of patients, and usually women are underdosed, and usually men are underdosed because of their higher elimination of 5-FU. So, and this has an impact on the toxicity. This is a retrospective analysis we conducted in the PETAC-3 trial, which randomized nearly 3,000 patients to adjuvant treatment for colorectal cancer to 5-FU or FOLFIRI, and as you see, in objectively measurable hematological toxicities, there were significant differences in toxicities, which were with women being at higher risk. So that we concluded drug targets, but also the optimal dose to hit a target with an acceptable level of toxic effects may be different between man and woman. Nobody had written this before in oncology. And this is just another example of where we analyzed a larger data set with more different chemotherapy regimens used in GI cancer as well in adjuvant chemotherapy for colorectal cancer. And it is confirmed that as well for the non-hematological toxicities, women are at significantly greater risk. So the role of genetic and non-genetic factors has been addressed in this study, and the DPD mutation, which is well known as a risk factor for 5-FU toxicities, does not explain this excess toxicity. If you look in the patients here with, if you look in the grade 4 toxicities, the percentage of women among those who have a grade 4 toxicity who have is smaller. Men are more likely to have a DPD mutation as a cause of the toxicity because of the higher plasma levels of 5-FU in women. So is pharmacokinetically based dosing a solution? Certainly this improves the situation. This is a randomized trial which used pharmacokinetically based dosing for metastatic colorectal cancer for 5-FU, and as you see, the response rate was significantly improved, and there was as well a trend for overall survival. So we can improve outcomes by better dosing 5-FU. This is also confirmed in this pooled analysis of stomach cancer trials for perioperative treatment, which observed a higher toxicity as well as a higher higher percentage of patients with a tumor regression grade of 1 and 2, and a significantly better survival in women, raising again the question, are men underdosed? And one of the most exciting findings was this poster from ASCO, a classical trial where they, the German AIO group, they compared included 400 patients to either upfront combination therapy with 5-FU irinotecan or capecitabine irinotecan and bevacizumab versus sequential treatment with 5-FU capecitabine bevacizumab, and irinotecan was added upon progression. And as you see here, the woman in this study had about the same response rate, whereas the man had a significant benefit from the addition of upfront addition of irinotecan, and the survival curves were corresponding that in the sequential treatment arm, the women had a better survival, and in the upfront combination arm, man had a better survival. So the survival curves were inversed in both treatment arm for men and for women. So I have no exploration for this. Confirmation of this observation in large trials and databases is necessary. Either there must be differences in tumor biology or differential effects of bevacizumab according to sex. But what I know definitely is that pharmacokinetic differences do not explain this observation. So in conclusion, precision oncology is more than exploring molecular markers and targeted therapy. A patient's sex is a cost-free and well-known modulator of treatment effects and toxicity that should be better overlooked. And I agree with the previous discussion that we have very much concentrated in the recent years of understanding the tumor. We learned as well that the microenvironment is important, but the interactions between the host and the microenvironment and the tumor have been largely ignored, and I think there is very much work to do. Men and women are more than subgroups of patients, especially in diseases with significant differences in epidemiology or outcomes. Men and women with non-sex related cancers should be considered as distinct groups of patients for whom different treatment strategies merit consideration. And you have seen this subgroup of the gastric cancers, which are such diseases with significant differences in epidemiology or outcomes, and interventional clinical trials demonstrating the benefit of sex-specific dose modification or treatment strategies are necessary before any recommendations for clinical practice can be made. So with this were the conclusions from a recent ESMO workshop on this topic. ESMO has decided to further continue to work on this, and there is a task force which I will have the pleasure in which I will work together with Sabine to better understand these differences. Thank you very much for your attention.